project, and I will select some of the titles. Says health system performance in Ethiopia. This is suitable for this conference. So this is part of the countdown project. Countdown is working for monitoring the progress of the countries for 2030. I don't know, there is battery running low. So, as an introduction, let's see the country's policy strategy profile since 1990 for the last 3 decades. And as the national health policy is formulated in 1993, following that, there is a 20 years health sector development plan that is implemented in 5 years approach. So this is another የሌላኛው ክፍል ሴሽን ነው የኛ አይደለም. So during the first HSDP plan, the major initiatives are the integrated management of child illness. They are formulated in 1997, and its focus is decentralization of the health services, community ownership, proper policies, and introduction of 4-tier systems, particularly on the primary health care units. This is the major agenda initiatives during the health sector development plan 1. When moving to the health sector development plan 2, more is focused on construction of health facilities. And there is also launching of health extension programs. And there is accelerated expansion of human resources for health. These are the major initiatives during health sector development plan 2. In health sector development plan 3, major focus is universal health coverage. A lot is told in this morning. And especially the upgrading the health extension work, programs in the urban, in the pastoralist area. These are the major pillars, including expansion of health facilities and health workforces. In HSDP4, the major pillar comes equity and quality of health services. And there is also expansion of the BMOC and EMOC services throughout the country. So having this after 20 years, now the second 20 years says envisioning Ethiopia's path to universal health coverage through strengthening primary health care. This is a 20 years plan, including the HSDP1, that is the previous HSDP1 and HSDP2 plan. So Ethiopia has implemented or formulated, developed such various strategies to improve the health of the population. What kinds of achievements are recorded or documented in Ethiopia? So the objective of this study is to monitor, to evaluate the coverage of health services. The second is to assess the quality of the service provided to the population, and the third is equity. What is the equity? You know, equity and quality, they are the recent agendas, even though they are formulated in Health Sector Development Plan 4, but they are reached or formulated the strategies and policies. So I don't know. So the method is the data source for this analysis is basically Ethiopian demographical surveys, and the second data source is the health facility surveys that is presented in the morning by Dr. Theodorus, like SPA and SARA, service availability and readiness assessment. And the other is the annual performance report that is published every year through the Ministry of Health to monitor the progress of the health system. And the analysis is in-depth analysis, regression analysis, equity, quality adjusted coverage analysis, and through review of different literatures and program documents. So I think there are very important figures that may be displayed. So the first is antenatal care 4+ service. So this is the analysis is concentrated on HSCP1, and at national level, ANC4 is increased from 32% to 43%. The average annual rate of change during these 4 years is 8% at national level. And the lowest is in Gambella, that is 0.6, followed by Addis Ababa 0.9. The highest is in Amara region, that is 15%. That is average annual rate of change. So every year the change is this one. So the highest is in Amara region and the lowest in Gambella region. And when we look Oromia, that is below the national one, that is 7.3%. So you can evaluate your system in terms of antenatal care 4+. So for the last 20 years, the change is every year or annually, it is 7.4 at national level. But in the HSTP1 period, it is 8.4. That is a great achievement to the health system during this HSTP1 period. But the target for HSTP2 is 81%. To reach that one, it needs 16% every year, annually. So this needs a great achievement, a great initiative to achieve this goal. But if things like go during the last years, it may not be achievable. This is one of our... So the drivers is the increasing, especially in rural areas, there is a higher achievement, that is 10 relative to 1.5 in urban areas. And most in underserved population, like no education, lowest or the poorest wealth quantile, there is a great achievement in that. So this is a very great achievement, even in regions. So it is recommended to achieve, to maintain and accelerate those efforts, initiatives during the HSTP1 period to achieve the HSTP1 or the newly revised plan, health sector investment plan. The second point is the quality of antenatal care. So as I have said, antenatal care 4+ is reached to 43%. ANC is reached to 74% at national level. Okay. Okay, so when we see the quality of care, when we say quality of care, every woman should get services like blood pressure test, sample taken, urine sample taken, blood sample taken. They take also iron tablets, and they should also informed or advised for the complication of pregnancy. And when developed this as an index, the national level is 36%. So you can compare 74% versus 36%. So actually, in terms of quality, the antenatal care coverage is 36%. and the lowest is in Somali region, that is 15%. This is 36%. And while the crude, the contact coverage is 43%. So not only counting the contact, but we focus on the quality of the service provided to the mothers, the pregnant mothers. When we compare the antenatal care 4+ versus the quality of ANC, you can see the Somali region in terms of coverage as well as in terms of quality is the lowest. While the central is 36, the highest is in Addis Ababa. So every region they can compare with Addis Ababa at least, or at least as the center. So Oromia is here, around here one. So the lowest, that is great work is required. Let's see the delivery. The volume of delivery, trends of delivery as a health facility. Where is delivery is occurred? So you can see this is hospitals, and this is the health centers, and this is private clinics. So when we say the large volume of delivery is occurred in health centers, and if you consider the regions, majority of the regions, health centers including other health clinics at total is 62%. The highest is in SNNPR and the lowest is in Harare region. You can find Oromia somewhere 60, almost near to that. So, but what is the readiness of the health facility in terms of to provide delivery, normal delivery? Those among providing normal delivery, the red one is, for example, if you take the SPA, the morning presentation, I don't know, it is 73%. Among those providing delivery service, only 73% of the health facility they are ready to provide services. So in terms of readiness, when we say readiness, are they signal functions available in that health facility? Are human resources or staff trained, and availability of guidelines, essential medicines, and basic diagnostic equipment? So when you consider that one, at national level, we have 73%. So majority of the delivery is, you can see, you can consider yours. So this is, you can connect the neonatal mortality versus the lower facility delivery, and more or less Benshangul Amara, the highest mortality, including the delivery is lower in the lower health facility. So our strategy, our implementation, our supervision should focus on lower facilities, especially health centers. So this is the place of delivery. Let's point one point. Here is public sectors, private sectors, and at home. So at national level, home delivery is reduced by 29% during the HSTP1 period. And surprisingly, this is urban areas. Home delivery is increased in urban areas. So you can focus. I think there is a time pressure. This is postnatal care. Postnatal care during the HSTP1 period. So there is average annual rate of increment is 54% for postnatal checkup for the mothers, while for 32% for the neonatal one. So the driver is, as we have said, so I don't know, maybe 5 minutes to see some of, let's jump some of the regions, but this is the neonatal mortality. The decline, maybe 2 minutes. So this is neonatal mortality reduction from 49% to 33% up to 2016, and there is an increase in 33%. And the major regions that contributed for this increment is, all regions they can increase neonatal mortality except those in Tigray and SNNP and in Addis Ababa. The highest increment during the HSTP1 period is in Benshangul, and followed by Oromia, and followed by Drido. I think this is very important. So this is inequalities As coverage is increased, inequalities also increased by socio-economic inequalities. So not only increasing the coverage, but inequality is a very crucial aspect. So this is the geographical disparities for neonatal mortality, as already stated, is Benishangul, Amhara, something Oromia is included. There is a higher neonatal mortality. That means it didn't decline from those period in 2000 and 2019. So I think this is a composite coverage index. This is a combination of 11 indicators. They are 54%. Now the coverage gap is the highest in Somali region, 76, and you can find in Oromia like 55% to achieve 100% coverage. So this is the universal coverage. Yeah. 1 minute.
No. You have to stop.
So I don't know. Universal coverage is 34.
We will ask you.
Only one slide.
No way. Stop.
Okay, this one. Let me. So this is neonatal mortality. Maybe this is one of the advantage to see the Oromia region. Now you can see neonatal mortality in Oromia regions. This is 39, 34, 28%, and it is increased in 35% in 2019. While antenatal coverage is increased, and facility delivery also increased. Skilled birth assisted by skilled professional is also increased. So when all the maternal care is increased, why neonatal mortality is also increasing? So this is the major question, should be further work. Sorry.
Yeah, it's okay. I mean, thank you very much for the system. I was a bit reluctant, and on top of that, you were so reluctant. So one of the mechanisms nowadays is what we have to produce. Not only what we produce, how we deliver is a system. So sometimes 10 minutes seems very small, and internationally 7 minutes is enough to say what you want to say. So with this, I will call upon Professor Zode. And for sure, I will not argue with my colleague. Try to use 10 minutes. Thank you very much.
So already started counting? Or?
Yeah, technology sometimes in favor of us and sometimes against us. And now it's not the fault of our presenter, it is the fault of the system and to some part the organizers. So you have 10 minutes now.
Okay, thank you. I will try to just finish on time. So thank you for your patience. Yeah, I'm Zaude from Jimma University. So I'm going to speak on a topic which is very much similar with the morning session. In fact, it would have been combined with that session because it's a very aligned one. Anyways, the point here is about the perspective of researchers and policymakers and program persons in terms of evidence utilization. We looked at that evidence generation and evidence utilization regarding what are the barriers, what are the enabling factors, how things are going on in the systems. So, as you all know, this is the building block of health system. According to well-standard accepted definition, there are about 6 components. Just those components are something that we always come across, and I don't have to focus much on that. But one important thing in this presentation, in my speech, is that health system research. So health system research is it is somewhat different from other types of research. That means not all type of research is health system research. So what does it mean is that health system research focuses more on downstream aspects of the programs. It is research that looks at how the program is functioning, how the program is, which is already accepted as a program, an effective intervention is going on, how policies are being implemented, how guidelines are put in practice, and so on. So it looks at what are the bottlenecks to the programs. In fact, it's very much aligned with the theme of this conference, bottlenecks to healthcare delivery, health system delivery. So research that looks at the barriers and the challenges as the program progresses is health system research. We can say that's operational research or implementation research and so on. So like clinical research are not really health system researches. So entirely health system researches focuses on fixing the program in the program as we implement it. So in our study, we just in our assessment we focused on all aspects of those researches. We didn't look at other aspects of research, but research that focus on health systems, how the health system works in terms of those 6 building blocks. So these are the objectives. We looked at the supply of evidence, how evidence is being supplied, the supply aspects. What is the institutional capacity in terms of generating this useful health system research evidence? Then the demand is, generation alone is not enough. Then what is the demand? Is there any demand? Is there any appetite for evidence uptake? How do program persons, how do policymakers really see it? And those are the point we just looked at. Then we looked at the barriers. Then what are the enabling environments for uptaking researches? Our methods are largely qualitative approach. We included respondents from two environments. From the first one is from research institute, including universities. We just included almost all research centers, national research institutes, common universities, especially those who are very much active in health researches. Then we also interviewed policymakers at different levels, from a ministry, including the partners, regional level, and so on. So So we looked at how things are going on, how do they perceive it, how do they analyze how evidence is being generated, and then how it is supplied. So the key summary here is that the national research institutes, including just we know very much, are less involved in health system research. Don't be surprised, because I said health system research is a kind of research that looks at how the program functions, how the program works, what is the bottlenecks inside the programs. So it is like fixing, you know, whenever you are implementing, you face some challenges, then it is trying to fix using evidence that is generated by research. So more active in applied researches, clinical researches, and regular surveys. That is very much important, but may not have very immediate input to the programs. The private institutes are very much, you know, demand-driven. They conduct demand-driven researches, usually in the form of consultancies. Universities, health system research is not that much located in university environments. Okay. The professional associations, they do have more opportunity, but less active in doing health system researches. The barriers to what are the barriers to evidence generation? The first one is for universities, the human skills, the human capitals. Most staffs are, as you know, young and less experienced. That's one challenge. High turnover, the retention capacities is very critical. Limited research for incentive for researchers, and there's a stakeholder engagement. If you ask, you know, probably assess many of this research which is going on, which has been we are presenting here even. How many of them are actually involved with stakeholders? It's a question. So that's very much limited. Research are not aligned to the priority. We know universities, we do have thematic areas, but thematic areas are really not priority. Priorities must be break down into questions so that it can be researched in a specific, and so that it can address specific problems. So in the morning session, it also said many researchers are actually donor-driven. That is true. They're driven by opportunities. That's one of the challenge. In fact, it's also an opportunity, but it may not be relevant to the specific program needs. Then the mechanism to prioritize health system researches. Do we have very, you know, well-adopted prioritization strategies for research at university levels? Do we set those priorities with regional health bureaus, with regional stakeholders, national partners? It's unlikely. So methodology to prioritize research priorities, those things are really absent in many cases. So I just, you know, interviewed this many professors for this purpose, and this is a direct quote from one of the senior professors, an experienced researcher. Research industries publications. No one knows, you know, what happens to it after that. Okay, who knows? One may have hundreds of publications, but we don't know where it goes after all. So this is my point. Thank you.
Thank you very much on time, and may I call upon Aicho? 10 minutes and 1 second. Yeah, I mean, it is it is also difficult to moderate when time is against you, so it will really steal your mood. But we are on the track now, slowly back, and now I will call upon
Okay, good afternoon. Thank you, Professor Leka, for chairing the session. My name is Aicho Siyum. I'm from Haramaya University. Currently, I'm doing my PhD, and the status is waiting for defense. So I did this PhD, this research as part of my PhD work by stating that high rate of non-vaccine targeted high-risk human papilloma virus genotypes in Ethiopia. It's very important, and it has a good implication on the future vaccine selection. So all my advisors it's a group work, and we worked together, Haramaya University, with that of Armor Hansen Research Institute. So I stick on the structure provided by the Oromia Health Law, so it has these kinds of components. So just to start, as an introduction, human papilloma virus is very important and also causing different public health problems. And there are different types of genotypes. So all those different genotypes are coming from based on the presence of variation on the late gene 1. The virus has different kinds of components. So all those different components play their own significant role. So differentiation at the same time, knowing their importance, highly rely on their late 1 gene. So this late 1 gene is finally will give us or translated to that of major capsid protein. So just by looking their nucleotide sequences, we can classify them accordingly. So cervical cancer is a major public health problem, as we all know, though, globally and within, even in our country. But the good thing is that this problem has a genotype-based vaccination. So there are currently 6 different types of vaccines available on market. And as of 2018, Ethiopia has launched this vaccination program just by targeting girls with age group 9 to 14 years. So this vaccine will protect the girls or the eligible women or girls, sorry, with only four different types of genotypes. So what the current clinical trial is telling us, there is a tendency of multiple infection. So within a given person, you can find more than 4 different types of genotypes. So their presence at a time can causes their own impacts by developing carcinogenesis more rapidly and more extensively. So we have to look at this point carefully. For example, they have said that human papillomavirus 51 and 58, when they are coming together, they can cause more rapid carcinogenesis process than that of the main genotype 16. So Ethiopia, as a country, currently we are utilizing partial genotyping, meaning we can only able to detect genotype 16 and 18, and we cluster others as high-risk groups. That will not give us a complete information. So with this understanding, we set all those different types of objectives. First, we determined at what level these non-vaccine targeted genotypes are circulating in our localities. And the other thing is at what extent multiple infection, those vaccine targeted with that of non-vaccine targeted are coming together. And we have assessed also cytological profile of eligible women using PAP test. So the study has been done in the eastern parts of Ethiopia by including 2 regions and 1 administrative region, and we used different tools to collect, and we used also liquid-based cervical swabs for lab process. So DNA, we have also extracted DNA using the star mark, and also detection at the same time genotyping has been done using the Seagen company product Anaphylaxis 14. So when it comes to the result section, so the majority of women had a single human papilloma virus genotypes, but the rest, near to that of 30% of them to have multiple infection. The second main result is that we have seen the proportion of those different types of genotypes. So we have seen all those 14 different types of genotypes, but of those human papilloma virus 16 and 31, which is the vaccine targeted group 1, highly prevalent, but then starting from like fifths, from rank 6 fifths to that of A's, has already occupied by non-vaccine targeted genotypes. So the probability of getting multiple infection is high. It is very, very important finding. The other point is that the distribution and composition of those non-vaccine targeted with that of that vaccine targeted group 1. So as we have seen that 16 and 31, it's the vaccine targeted one. They are coming most importantly in different number of women. So out of 13, those women infected by multiple infection, we have seen all those different kinds of proportions, combinations, sorry. And the last finding is that we have seen also the non-vaccine targeted genotypes associated with that of the cervical, formation of cervical lesions. So previously we have seen that the high risk group 1, especially genotype 16 and 18, are causing significant lesion on the cervix. But on our findings, there are different kinds of findings. So on that, what we have seen is that the formation of lesion will not be will not be based or will not be based on genotypes. So there is a probability or there is a tendency of both groups can cause malignant lesions. So as a policy implication, there was a high rate of non-vaccine targeted human papilloma virus infection genotypes near to that of 51%. Out of 110, we have seen 51% of them have non-vaccine targeted genotypes. This information was coming as a result of we used extended types of genotyping. There are different methods, partial, extended, and complete types of genotyping. So throughout the country currently, these complete and extended forms of genotyping are not applicable. So using or taking initiative to launch these kinds of diagnostic tool is very important for the country at large. The second one is there was a high rate of genotype heterogeneity. So on the previous paper that we have published, we have seen a significant genotype variation or heterogeneity in the study area. And this was already presented on the other international conferences that was held in Spain and Germany. So this information also coming as a result of these extended types of genotyping methods. And this also has an implication that currently we are introducing a vaccine targeting only 4 types of genotypes. So if there is excessive types of genotype heterogeneity, we have to look at what kinds of vaccines for the future we should implement for this country. And there is also, there was a considerable rate of multiple infection. So always while we are treating or while we are taking those visitors as a probable cervical cancer cases, so we need to take the presence of multiple infection because the time taken for the formation of carcinogenesis quite shortened as compared to that of the single genotype infected individuals. So finally, let me acknowledge this work was a group of work. Intensive support has been provided. I have gotten from Armor Answer Research Institute in different ways. So I deeply want to acknowledge Armor Answer Research Institute, my home institute, my advisors, and Ms. Santina, also the management of those different hospitals, study participants, and those individuals involved in the lab work. Thank you very much.
Thank you very much, Haicho. Exactly 10 minutes. Thank you very much once again. And I will call upon Dr. Tamasgen.
Okay, thank you, Professor. So, in the morning, we're discussing about evidence generation and related issues, and now this is about utilization of evidence-based practice. So the title is Nurses' Perception of the Hospital's Culture, Readiness of Evidence-Based Practice Integration in Hospital System, and its predictors in Western Ethiopia. So when we say the culture, hospital's culture, so it refers the beliefs and the values of healthy professionals within that healthy facility. So evidence-based practice is, as already said, it consists of 3 important things. One is research, the scientific research, and the other is expert opinion. When we say expert opinion, so expert opinion is obtained from what we read, what we do, our skill, and also what we can suggest from that. And the other is from patient preference. Patient values are also very important. So we combine all these 3 and implement evidence-based practice. And there are varieties within healthy facilities and also healthy professionals in implementation of evidence-based practice in the current health system. And our country is also implementing what we call evidence-based care, but institutionalization of this evidence-based practice is lacking. And priority from leaders, from healthy leaders, is also low. And there is also a gap in attitude, knowledge, and practice among healthcare providers. And all healthcare providers are expected to implement evidence-based practice, but so this mainly focuses on nurses because they form the largest population in the hospitals. And when they implement this, so the healthy outcome, the quality of care, patient safety is going to be improved. So integrating their beliefs and attitude in implementation of this one is very important. And they claim some problems, some factors. For example, resource constraint, lack of research experience, lack of access to research database and the infrastructures also. So no study was conducted in Ethiopia to assess nurses' perception of the hospital culture and readiness of healthy facility to implement evidence-based practice, and these are the general objectives. So we want to assess their perception about hospital culture and readiness to implement evidence-based practice into their system, and also the level of perception of nurses, and then some barriers and the facilitators that can help us implement evidence-based practice. So the study area, so we included 2 tertiary hospitals in the Western Ethiopia, 1 general hospital, and 3 primary hospitals. So we study participants 412 nurses who stayed there for at least six months. So we used the organizational culture and readiness of system-wide integration of evidence-based care practice, which consists of 25 items, and it was also validated, and sample size, we included all eligible nurses in the healthy facility. So data was collected by self-administered questionnaire, and statistical analysis, we just used spaces and to describe some variables, and also regression analysis was also made. So when I come to results and discussion, so the response rate was 93%, and the mean age of the participant was 30 years, and the mean age from graduation, from the time of graduation, is 6 years, and most of them, 86% of them were bachelors, and 50% of the participants were from the tertiary hospital. 1 comprehensive specialized hospital, about 30%, and 20% from teaching hospital. And only 33% received update training through their continuous professional development, and only 16.3% of them received research-related training in the last year prior to the study. And only 26.5% have received any mentorship from their leaders. When I say from their leaders, from matron or from their heads, and also from the medical the medical director and the CEO. So the overall hospital culture and readiness score for system-wide integration among nurses in 6 hospitals was 30, it is 70, and it is equivocal. And this is low when compared to, this is just comparable to a study conducted in Ireland, and but it is lower when compared to a study conducted in USA. The study participants in USA, they were from academic environment, and they also the one from Ireland, they complain lack of mentorship and the lack of institutionalization of resources. And also, when I say resources, human resource like nurses with masters and also PhD practicing in the healthy facility. And when I come to the facilitators and the barriers, so this age working in tertiary hospital and mentorship are the factors identified. For example, lack of mentorship is it negatively affects the implementation of evidence-based care, and working in tertiary hospital as a facilitator. And so a study in Ireland which reported insufficient evidence-based champions. So there are also in that study and in our study we didn't detect the champions, the best performance, and mentors. This is just because of lack of master's holders and also PhD holders practicing in the hospital. So this calls up about doing something to the curriculum. The curriculum. And the other is the nurses perceive availability of institutional resources, institutional prioritization of resources, and expectations of evidence-based practice. So in these studies, there are also lack of some equipments like computers, internet access, and also financial support to give training and practical sessions. So policy implications, so the perception of nurses toward this hospital culture and readiness score for system-wide integration of evidence-based practice is equivocal. So we need to do something. There is a need to engage all resources, especially human resource having nurses with masters, PhD, practicing in the healthy facilities, especially hospitals, so that they can mentor the junior and also generate evidences and guide the junior nurses. And increase leadership commitment. This is also very important because it needs resource, it needs policy, so leadership commitment is also very important. And the other is, so it should be, there should be a policy that can compulsory of its implementation. So there should be a strong policy that monitors this implementation. And the other important point is having doctorally prepared nurses. So as like having residency program for physicians, so one can also have residency program for nurses, so that we can get experience it with good educational status who can monitor the junior nurses. Thank you.
Thank you very much. So I will call upon the presenters once again here, and for the interest of time and also that I'm not able to comprehend and summarize it, it deems not necessary, but until the presenters take the place, I will say few words, 1 minute. First, I have to apologize for Mr. Ashanafi for he was not displaying and a bit disturbance. That's not his fault. And then I thank you all. As you can see from their presentation, we have 4 important institutions like EPHI, where Mr. Ashanafi has presented about the understanding, and mainly he emphasized the equity and the quality of the data. And then it goes to Southwest, to Jimma University, where Professor Zode said research, or quoted, quote unquote, research with publication, which has truths and which has reasons. Back and forth there was, that's why GRIP, or how research is changed in policy, who will change to policy, what are the quality of data generated at home. There are so many questions that we have really had many home tech messages this morning. I really appreciate. I have so many questions. So it's a unidirectional, and that is where, and he has shown also. And then goes to the East, Haromaya University, where Mr. Aichuno really tell us the genome sequencing of human papilloma virus, and the finding is so interesting. Because the non-vaccine targeted are the more circulating here. It has different scenarios and connotations when we go deep into this science. And luckily, I will talk to you soon in Jimma. We will have proteomics and genomics, which can detect both, and we will compare the result. And then goes to the other side to Wallaga University, where he capitalized about nurses and nurses' perceptions, the highest population in the hospital, and also the one who is equivalent to mothers in terms of, or in patient perspectives. This is enough for me. We have some 28 minutes accordingly. I used 2 minutes, so 6 pertinent questions. Please, I'm very democrat, but time is against. 1 question from 1 person, so that we will give them time to reflect. So 1 person, straightforward, 1 question, and name either of them. Who is the moderator, please? So, Siddhi Sovicha. Age 1, Professor Seleshi. Number 1.
Leila.
Aitayim ቡና ጠጥተናል፣ ምሳ በልተናል። እጃችሁን አውጡ መጠየቅ የምትፈልጉት። then we will have time. No? No question to them? Number two. Number two, okay? Slowly coming. 3. No more? No more question? 4. Okay. Think over it. If time allows, I will come back. So, number 1.
Thank you, Professor Zallake, for giving me a chance. First of all, I would like to thank all the presenters for their informative and clear presentation. My first concern goes to Mr. Ashenafi. He presented very well about the issue of maternal health service coverage with its indicators for maternal and child health services. My concern is really, I was wondering if you were presenting about the issue of early antenatal care and antenatal care 8+, because nowadays antenatal 4+ is outdated, and the ministry is shifted to these flagships, just leaving antenatal 4. And the second concern is for Professor Zode. Yeah, he has presented very well about health system research, as it is somewhat different from other researches. And on his finding, even though it is qualitative, at National Research Institute, they were less engaged in doing health system researches. But my concern is, for example, Ethiopian Public Health Institute is part and parcel of the Ministry of Health, and on behalf of the Ministry of Health, they are engaged in doing all types of research, focusing on health system. For example, during the morning time, one of our colleagues were presenting on service availability and readiness assessment. That is purely targeted on health system. So I was confused when the result showed less engagement. For Mr. Aicho, really, you presented informative way because HPV is nowadays a great concern at global level. Based on that, Ethiopia is taking this as an issue and now providing vaccines for the fourth time, last time. But we were not considering the genotype as a Minister of Health. We are simply providing, assuming that the vaccine is given during the early age, as they are not infected to any genotypes. But my concern is about 52% of the cases are just targeted as non-targeted vaccines coverage. So in this case, can we say those vaccinated girls are not protected for some percent of the coverage is my question. And also nowadays there is a great discourse across the world because previously the countries are giving 2 doses of HPV vaccines, but now the debate is to shift these 2 doses to 1 dose without having any evidence. If you, from your reading, if you come across this reading evidence, please, I wonder if you tell us. Thank you very much.
Number 2 there, I gave him 4 questions because he represents ministry, at the same time he's my close friend, so please make it short question.
Okay, thank you. Just my question is just, it's one. It goes to Mr. Ashenafi. I saw one graph that indicates that the relationship between perinatal care and neonatal mortality. Theoretically, we know that perinatal care may reduce or challenge neonatal mortality, but in your case, they goes parallel. Please, would you clarify why that happened? Thank you.
Thank you. Number 4. Number 3, I mean.
Okay, good afternoon, everybody. I am Taddasa. I am a general surgeon from facility, and I do have 2 questions for the first presenter. For a number of reasons which was already mentioned, nowadays we have a significant number of maternal and neonatal mortalities, despite the big efforts our health system is doing. But we can consider the understanding of the mothers, of the needs of follow-ups, and also the adequacies of the health facilities, and also the physical closeness of the health facilities. And we need to consider the availability of infrastructures, ambulances, and so on and so forth. But above all, what is the place of the closeness of health professionals to the communities? And the second question I have is for Dr. Tamasgen. He has mentioned that nearly 26% of nurses have not received any updates or any trainings on evidence-based practices. And as we all know, nowadays in modern day medicine, we need to practice evidence-based cares. So with regard to this, what is the place of our training institutions? What is their roles? And through the continuous professional development, the alliance and the practice they have with CPD centers. And also, what is the place of digitalization of data in practicing evidence-based medicine? Thank you.
Thank you. The first limited question 1.
Thank you, Professor. Actually, my question already addressed by the previous colleague asking Mr. Ashanafi, the paradox between the prenatal care access versus mortality increment. So I already asked, but let me change my question to, do you suggest further evidence generation like qualitative study? Or do you think that one is the reality difference or the evidence generation process gap? Thank you.
Thank you very much. With due time, I will give the floor to Mr. Ashanafi since he has a couple of questions.
Thank you very much. The focus of this study is to connect the health system performance with health outcomes, specifically on the readiness of the facilities and the quality of the services and equity. So there are identified health-related factors and non-health-related factors. When we say non-health-related factors, there is expansion of roads, expansion of communications like telephone, everything. There are great impacts on the improvement of health outcomes. And the health-related factors, we assessed the 6 components in terms of the availabilities of the improvements of the maternal, neonatal, and child health outcomes. I don't know the association between perinatal and neonatal mortality. My figure is neonatal mortality versus delivery at lower facilities. That is, if there is, I don't know that slide, but when there is, in Ethiopia, there is majority of the deliveries at lower facility, health centers and lower clinics. But when we see the readiness of this facility, life-saving interventions are not available in the health centers, or only 56% of the health centers or lower clinics avail that life-saving medicines. So I am trying to locate or connect that relationship between neonatal mortality versus lower, and that shows a great or positive relationship with lower facilities. I am not showing, but if but when we say the hospital, there is a declining hospital versus neonatal mortality. That is a great impact, but I didn't see the neonatal, the perinatal versus the neonatal mortality, even if further study is required, as suggested by that. Qualitative research is required. Is lower facility delivery really associated? The statistics like this, but what is the real ground on what is the reality on the ground? Of course, SPA answers that questions. Only 56% of the facilities are ready, health centers, to provide normal delivery. We are not conducting even CS analysis, normal delivery. Those giving normal delivery, only 56% of health centers are ready to provide that delivery. And as suggested, you know, the WHO guideline is also changed, 8+. We will further look at 8+, but our further is at any NC contact, how was the quality of the service provided to the pregnant mothers in terms of quantity? Are they taking blood pressures? Are they taking blood samples? Are they taking all 6 components, including the antenatal care is, who is providing the antenatal care with skilled providers? So when you combine them, there are 7, and the average of the 7 that gives the quality of antenatal care. So when we relate to that one, you know, NNC is 74%, but when we adjusted the content of the quality of antenatal care, it is 36% at national level. So we don't rely on the contact, or we don't focus on contact of ANC, but quality of ANC that may be associated with the quality of the services, the ANC, and other services. So that is the closeness of the health facilities. We have done the health workforce density. There is one slide, health system strengthening index, that is calculated from health workforce density, health facility density, and bed density as an input, and the output is outpatient utilization service and inpatient bed per year. So input, when you compare input versus output, you can compare the efficiency of that system in Ethiopia. So that is 34% only. So there is a huge investment on the inputs, but the output is very low. So you can compare so that is the other, I think, others are comments. It is a further 3 years study. We will see those recommendations based on the availability of the data. Thank you.
Thank you, Mr. Shanafi. You have one.
Any question? I was not here, just sorry.
No, his question is, if I'm not mistaken, you say universities and research institutes are less involved. And why? As EPHI is right hand of the ministry, in short.
Yes, they are less involved in operational researches. They are much more active in doing regular surveys, very big surveys, clinical studies, sometimes very even advanced, studies which generate knowledge, which may not have an immediate implication to the program. That is it. So it's not about, I'm not referring the entire research process, but focusing on more operational program-based research that focuses on how the programs are functioning, how the programs are working. Just we see, health system actually see programs as as a machine. If something is wrong with the machine, we have to fix it. Otherwise, it stop working. So health system is a kind of that research that looks at, that tracks the challenge in the programs and continuously, generate evidence on how to address it, how to tackle all those challenges. So otherwise, I was not talking about much broader research areas. So, but that sense, no matter the finish. Thank you.
Shall I continue? Okay.
Yes.
Okay, thank you, Professor Saleshi, for the questions and explanations. On the first question, yes, we found that more than half of study participants had non-vaccine targeted human papillomavirus genotypes. But in our country, as of 2018, we have already started HPV vaccination. So those vaccine, that vaccine has a capability of protecting us from 4 different genotypes. Of those 4, 2 of low risk types, meaning causing that warts and other causes. And the rest 16 and genotype 16 and 18 are causing cervical cancer. And as per the recommendation made by WHO, 70% of the global cervical cancer can causes as a result of these 2 genotypes. And we received that recommendation and we implement the vaccination program in our country. And when we take it in our context, the scenario might not be similar to that of as to that of the WHO's recommendation. So we can say that the current vaccine is highly protective against the 16 and 18 types of genotypes, but still there are significant number of women who are eligible for this vaccine are missing. So there are other options like nonavalent and other types of vaccines. So we have to reconsider or we have to reshift the existing scheme of vaccination program. I think the ministry and the regional health bureaus and any stakeholders can look at these kinds of missing opportunities. So just finally, at the end of vaccination, we are now going to evaluate the efficacy of the vaccine. So at that time, we may not get an appropriate kinds of or a desirable kinds of outcomes. So before reaching on that stage, let us try to see all those different tackles from the beginning. That was, so for your first question, we can say that it is protective still, but still we need to see other areas that has not be covered by the vaccine. On second question, yes, I was involved also in one international conference, and the World Health Organization has been provided or has been delivered the current initiation of launching a single dose vaccination. And most recently, my advisors, Dr. Abraham, Dr. Adana, and Dr. Andargacho has already published whether it is a good opportunity for us, for the developing countries or not. They have already published that paper. What was representative at that time telling us that they have made different kinds of clinical trials, especially in India and Pakistan and some other Southeast Asian countries. And there was a high dropout rate as a result of 2 doses and 3 doses. And but when they try to evaluate the coverage and efficacy of the vaccine, still it is remained not kinds of declination and other issues. And they try to ask that, is there any differences between single dose and 2 doses of vaccination program? So they didn't find any kinds of changes. So currently, just to minimize these dropout rates and other challenges, they have recommended single dose vaccination program as of this year, especially for developing countries. So that was the initiation made by WHO.
Thank you.
Okay, thank you. There are two concerns. One is about role of teaching institutions, training centers in implementation of evidence-based care. So, as we know, evidence-based care, evidence-based practice is not a new issue for the world, but it is recently introduced into healthy facilities in our country. So I feel teaching institutions should do two things. One is about curriculum. The healthy professionals we are producing should know about evidence-based care in detail, how to implement, how to generate evidences, and also how to collect evidences. So we didn't prepare our healthy professionals in this way. So we need to give training for already produced healthy professionals. So we need to improve their understanding about this evidence-based care through training. And the other important point is about digitalization. So it is about data handling. If you handle data, you're doing the appropriate interpretation. So definitely it improves quality of care, and also it helps us to implement evidence-based practices. But it is not easy. It's not easy. It is very resource-intensive. Digitalizing a given hospital is not easy. So these days the government is implementing it in some hospitals and also in Addis Ababa. So in the western part, we are planning to digitalize our hospitals, our healthy facilities, so that data handling will be significantly improved. Thank you.
Thank you, all the presenters, for a nice and precise reflection or answer. With this and with the interest of question, I'm so happy, so glad, and thank you, Oromia Health Regional Bureau, for inviting me and for this brief short in front of you, and for such diverse scientific and not only scientific but also timely. I'm so happy, and please applause for those presenters who have worked and who have really presented. Once again, thank you very much, and I would call upon, I guess the organizers have a message, and from my side, it's a good, and I wish we will continue the rest. Thank you very much.
Asumaan xumurree baana jennee waan yaanneef Marsaa 2ffaas itti fufa. Kanaaf Professor Seleshiin itti fufa jechuudha.
Okay, thank you very much. I'm going to moderate these sessions. I think I'm told to continue. If we have a tea break session.
Okay. I know talking on individual, talking with individual who get tired is very difficult. Just I make it very brief and short. As you can see from the picture, I'm talking about these two guys, about the mothers and about the child. So, to give you an overview, surviving and thriving is and transforming is a core pillar for every child and for every woman. So actually to check and to know how the treatment and service has been gone in a good direction or on wrong direction, we should have to know and have a comprehensive quality data and real-time data. As you know, on the development goal, this agenda has been set to reduce maternal mortality rate to 70, neonatal to 12, and under 5 to 25. In the same way also, we both the same goal, and overarching in Ethiopia, within the health sector transformation plan to reduce maternal mortality 279 and under 5, 59, infant 45 and neonatal to 33 and still, no, 21, sorry, and stillbirth to 14 by 2015. But still we are ranking among the highest mortality rate for both maternal and child health. So it's obvious that we should have to count and track our work, but still we are suffering with the quality data and more depend on the cross-sectional data in the same way on the inconclusive data and the very incomplete data. For that, I brought to this session to use the longitudinal data, which are post-millennium development goal data from demographic health surveillance systems. It is started from 2015 to 2020. So I present today the 6-year trends of maternal, neonatals, and under 5 child mortality rate, cause of the deaths, and also determinant using the more reliable data source. This is a study area. We are found in Eastern Ethiopia, so the study area is focused on Qarsa, Haramaya, and Harar town. So it have the rural section and also urban section, and then the same way also it have a semi-urban context. So the system is we are recording, analyzing, reporting, and also investigating the same way. This is an active surveillance that we have doing at a university level. From this, while we are collecting data, the data is collected using electronic tablet, and the data collected from the field directly sent to the data servers, and also it have a frequent checkup and also quality measurement. So the days of the individuals has been ratified by verbal autopsy, not by physician assertment, using interview 5 algorithm. Based on that also, we conclude what is the main leading cause of death for infant as well as for maternal death. We try to use a different software, STATA-R, ArcGIS, and interview 5, and we try to present with a descriptive and also using high levels of analysis, and also we assign days using interview 5. We used a large numbers of respondents. For pregnancy loss, we followed 70,000 women. For prenatal mortality, 90,000 women. For neonatal, 34,000, and for under 5, 36,000. And for maternal mortality, we followed the all 158. The one thing that we are adding is the definition of maternal mortality rate is confining on 42 days. We try to challenge whether the mothers died less likely after 42 days. So we go to for 12 months and also try to look how much of the days might be sustained after 42 days. For pregnancy loss, as you can see from the figure, 2.7% pregnancy lost among 1,000 births. This is also a huge numbers. It's commonly associated with ANC surveys, daily labor, the work of the individuals, and also whether that pregnancy is wanted or unwanted, and the others health service related situations are directly associated with pregnancy loss. Perinatal mortality, as you can see from the trend of analysis for the 6 years, that is post-millennium development goal, it seems tracking down, but still the rate and also the frequency, the pace is not as such attractive. Still, the place of the respondent, parity, gravida, and health service utilization, and birth weight and the preterm, and something like that, associated with the levels of the individuals also associated with this common problem. I am interested to talk more about under-5 mortality. As you can see, we tried to fit a linear line, but we couldn't because it has fluctuated. As you can see, after 2019, it became fluctuated ups and downs, and still we have 48 under-5 mortality per 100 live births. This, as you can see from this table 2, the reduction rate is also still requires more intervention. By this pace, we wouldn't be reached to that levels. The other thing that also we could assess about the cause of death, among the top cause of death, diarrheal disease is still taking the highest. Still, these are preventable types of cause. As far as we have vaccination for rotavirus, as far as we have a lot of hygienic protocols and the like, still the leading cause of the death is diarrheal disease and the congenital malformation. Actually, in Ethiopia, the congenital malformation is still coming to as a prevalence problem for neonatal and under 5 days. Still, we try to look into the variation. The variation is still existing among them. So the hazard ratio for all is also seen being rural, being poor, and also not having ANC, and also if the child is preterm, and also the low birth weights are directly associated with this problem. We try to look into analyze the geospatial analysis, whether the distance from the main road and health facility have directly impact on the death rate. As you can see, we try to look into each year by year, from 2050 to 2021. Still, the problem is sustaining on that rural place. As you can see, Walta Bilisumma, Ramata, Tola, Dolu Salama, and the Jaba Water Kabeles are the highest rate of deaths recorded. When we are looking from the map, they are far from the main road, and also the health facility they had might be have not fully cubed and also have a good quality healthcare provider. Maternal mortality rate, as you can see from these tables, almost it's stagnated. Currently, we receive the report that maternal mortality rate is 200 and something like that. But according to this longitudinal and very reliable data, still we are recording 484 maternal mortality rate per 100,000 live births. So we can challenge now using the inconclusive data. We cannot talk about the maternal deaths. So while we are following the subsequent years, still the death rate is not reducing significantly. It is fluctuating and almost, as you can see from the confidence interval, it is overlapping. So we try to look what's the main cause of death. So far, we received from hospital, hemorrhage is the leading cause of death. But from the community, the reverse is true. In the community, pregnancy-related sepsis is the #1 cause of death. So far, we are focusing on the hemorrhage, but the missing one is found in the community, that is sepsis is the leading cause of death. As you know, more individuals give birth at home. That might be the issue. This is the interesting point that we try to compare the days before 42 days and the days before after 42 days, up to 1 year. Still, you can see the variation by the days from the International Classification of Disease. So far, the infection is also sustaining after 42 days until 1 year. So this needs an implication for policy discussion. So by this speed, I question we couldn't reach the Sustainable Development Goal and HCP2 goal. And infectious disease is a predominant cause of pregnancy-related deaths even after 43 days. So still it is a sustaining cause and followed by non-communicable disease. So maternal deaths sustained beyond 42 days, yes, we urge policymakers also to redefine maternal days until 1 year. Child and mothers died because of preventable disease, finding question the quality of primary health care and universal health coverage in the country. So also, this may urge decision maker to focus on the multi-complex ecosystem of reproductive life course. This is what I wanted to say. We can follow the multi-complex system from the pregnancy until the child developmenthood until adolescent. So this recommendation, because I use my time, thank you.
Thank you, Dr. Marga. You exactly used 11 minutes, not 10. So we thank. So now Dr. Malkamu will continue. Dr. Malkamu, I think he's a scholar from Jimma University. Even though I don't have his profile on my hand, you are expected to finish also within a given 10 minutes. Thank you.
Thank you, Professor. As you rightly said, I'm coming from Jimma University. I'm a pediatrician by background and getting involved in different clinical and community-based studies, teaching and providing clinical service at my institution. So this is the title of my presentation, Management of At-Risk Mothers and Infants Under 6 Months, which is a cluster randomized control trial. I'm presenting on the behalf of my co-authors and collaborators listed here. This is the presentation outline. To begin with, globally millions of infants under 6 months are small and nutritionally at risk. As we might know, the first 6 months of life is very crucial developmental period, and nutritional deficits occurring during this period are associated with lots of short-term and long-term complications, including increased mortality, impaired development in the long run. And despite this fact, these age groups are significantly left behind in many settings compared with their older age counterparts. And several challenges exist around these infants, which are leading them left behind. To mention some of them, there is a major issue understanding the magnitude of the problem in this age group, because we assume they are on breastfeeding, the mother takes care of them, so they get the necessary nutritional requirements. And the other major challenge is there is a poor tool to identify them very early in many of the settings, because in order to diagnose malnutrition, we just rely on weight for length only, which is problematic in many contexts, like difficulty of measuring, accurately interpreting, and the like. And it's, most importantly, it's very late to detect them with malnutrition by using this anthropometric index. So, taking this into consideration, we wanted to fill in some of this gap through cluster randomized control trial, which we are conducting in 2 settings in Ethiopia, using what we call the MAMI, or Management of At-Risk Mothers and Infants Care Pathway. We are conducting this study in Jimma Zone and Dadar district of East Hararge Zone. This MAMI Care Pathway has an advantage over the other approach in that it is an integrated care pathway across the reproductive health, nutrition, maternal and child health. It's built on and supports the IMCI guidelines, which we all have been using for the last several decades. And it includes clinical, feeding, growth monitoring, maternal mental well-being, which is neglected in most of the cases. And it includes follow-up, especially up to the age of 6 months. And we use this MAMI Care Pathway package, which can be available at these sites. And there is the MAMI Global Network, of which we are also part as a country. And this is a network of programmers, researchers, academicians, and service providers who are advocates for these neglected age groups. So we have 4 key objectives, which are divided into 2. The first 2 objectives are conducted as a formative study in order to make preparation for the major RCT. So it was one of these objectives was assessing the perception and understanding of infants' malnutrition and its management through a qualitative study. We also did estimation of the prevalence of malnutrition and degree of overlap between the different kinds of malnutrition through a quantitative study. These 2 have already been accomplished, and right now we are conducting the major RCT using the intervention care pathway through a cluster randomized controlled trial. And we are also trying to evaluate the process of this RCT so that we can understand the challenges, the opportunities from the very beginning rather than carrying out this later on. So we label this as a process evaluation. These 2 are still going on. We have some preliminary data, but we didn't yet finalize. So I will not be talking a lot about this. Methods-wise, as I've said, we are conducting this in 2 contexts, the relatively stable context in Jimma zone and relatively humanitarian context in East Hararge zone. And we did a quantitative survey, which took 2 weeks survey of infants visiting 18 health centers, mainly at the immunization clinics and under 5 clinics. And we measured the anthropometric measurements using the standard WHO and USAFE procedures. For the qualitative studies, we conducted in-depth interview of parents, healthcare workers, programmers, and policymakers. And as I said, for the RCT, we are conducting 2-arm parallel group randomized control trial using the Mami Care pathway, and our clusters here is the health centers. And for some of the work, the publications have already been made, so I'm not going into discussing the details of the methods and the results, so that any interested individuals can browse and get the necessary details from these 2 articles. The first one is for the qualitative, and the second one is for the quantitative study. So first I will be briefly discussing about the results from the quantitative study. As you can see, we conducted the study in 2 settings. Overall, we surveyed around 1,060 infants, and the final number analyzed was 1,037 in both contexts. And the key finding is, and unlike what we expect, all the anthropometric indices like the weight for age, the length for age, and weight for length were all below the WHO recommendation or WHO standard median. So that indicates malnutrition, which we are dealing with during later age, arises very early in the first 6 months of life. And 1/5 of these infants surveyed had 1 or more forms of anthropometric deficits. And nearly 11% of them had severe, multiple forms of anthropometric deficits. And unlike what guidelines recommend, the weight for age was found to be better in performing or in identifying infants at risk of malnutrition, but the current guidelines, local as well as international ones, do not use this simple to conduct and easy to detect other forms of malnutrition. So this has an implication which we will be discussing later on. On the other side, you see the figure which indicates the rate of breastfeeding in this context. Unlike we expect all infants are breastfed in the first 6 months, most of the infants are started on complementary feeding very early, like around 10 weeks. And introduction of water and other liquids occur very early, which is one of the factors contributing significantly to the high burden of malnutrition in these age groups. And this one is just a comparison of the different anthropometric indices we used. We categorized the infants into 2 groups, those less than 6 weeks and those between 6 weeks and 6 months. So this indicates that the anthropometric index we commonly use, the weight for length, detects only very few infants compared with MWAC or the weight for age, Z-score. And this one is findings from the qualitative study. And we tried to put things into 5 major themes. I'm not going into the details of this, just to highlight or to link this with the quantitative findings, like in the theme 2, perceptions regarding feeding. As I've indicated on the quantitative, many participants who took part in this indicate that initiation of complementary feeding is a must, and it has to be done very early, which we need to target. The other is the last theme 5, identification and treatment. As I was highlighting earlier on, finding from this qualitative study also indicates that there is a major difficulty in conducting the anthropometric indices in order to identify infants very early. So we need to have probably another way of identification and treatment in these age groups. So with regard to policy implications, we have something we recommend. Routine screening of all infants under 6 months and their mothers or carers at any contact point within the service delivery should be in place in order to detect these at-risk infants in the first few weeks or few months of life. So as I said earlier on, this was a finding from a study or survey done in the immunization clinic. So the large majority of the infants are normal. So unless we target this presumed to be normal, probably it might be too late to detect them when they come to inpatients or outpatient visits. And there has to be a way we can shift from the complex, difficult to conduct ways of assessing infants' malnutrition to a single and easy to conduct like weight for age or MUAC. And additionally, we have to move from anthropometric based indicators to probably some other comprehensive ways of assessing these infants as well. In fact, these are in line with the current WHO recommendations. So in 2023, WHO has already launched the new guideline where such recommendations have been already implicated. And some members of our team have been advocates in revising these guidelines. And we need to use evidences generated through our RCT. As I've said earlier on, we have collected significant data, like we have enrolled nearly 2,200 infant mother pairs, and 60% of them have been followed up to 6 months of age. So in 3-4 months' time, we will have some preliminary data which we can share so that these guidelines, findings could be reflected in our upcoming guidelines. And this is the acknowledgement. Thank you very much.
Thank you, Dr. Zalalam. So without taking time, I will call upon Dr. Salamawit Abebau. She is presenting the research conducted in eastern part of our country, around Hararge area. You will use also the recommended time.
Okay, thank you. My name is Samrait and I'm from Hararge Health Research. And Hararge Health Research is a collaboration between Haramain University and London School of Hygiene and Tropical Medicine. And I'm going to present the CHAMPS results of CHAMPS 3 years result. And I'm going to use the Oromia Health Bureau outline. So as an introduction, the global mortality rate has shown some decline over the years, but it's still high. It's still at 38 diseases per 1,000. And the other neonatal mortality and mortality among children and youth, it showed more or less a steady rate. So the majority of world population doesn't have a vital registration system, and it's very inadequate. And the other thing is verbal autopsy and clinical records have important limitations, as these documentations as we have poor documentation and poor data keeping, and pathology autopsies can only be carried out in exceptional settings. And also knowledge of cause of death is a critical guide to effective strategy and health planning. And with these three major issues, we have come with a new approach to determine the cause of death, and it has been validated, which is minimally invasive tissue sampling. CHAMPS is a child health and mortality prevention surveillance, and it's a network that goes around the Sub-Saharan Africa and South Asia. So the overall objective of this CHAMPS network is to track the definitive cause of death for child in the sites through Sub-Saharan Africa and South Asia, to produce and disseminate high quality data, and to enable the sites to be able to leverage this CHAMPS investment so that they could prevent mortality. So these are the CHAMPS surveillance sites. It's in the South Asia and Sub-Saharan Africa. Ethiopia is included. And we are, in CHAMPS Ethiopia, we are currently using the Haramea, Harar and Qarsadi DSS sites. So when we come to the methods, so our methodology starts with the social and behavioral sciences to the data to action. So the first thing we did was since we are taking post-mortem sample from a dead body, it was very important to make sure that the community accepts our project in the process we are going to do. So using community advisory board, using religious leaders, and also using theater for development and showing them what our project means. We made sure that our project was accepted among the community, And the next thing was the mortality in pregnancy surveillance. In the mortality in pregnancy surveillance, we had mortality days notifiers in the community, and we also have pregnancy surveillance so that we could detect complications early. Then comes the specimen collection. In the specimen collection, we collect tissue from dead body using a needle, and it doesn't cause any dysmorphity in the dead body. So we take sample from lung, liver, heart, and brain, and non-tissue samples from say safe blood and nasopharyngeal swab. Then we go for clinical data and clinical data verbal autopsy. So we gather information, we do verbal autopsy from the parents, and we gather information regarding the what was happening around the days of the child, and we also do data abstractions, especially if the cause of the days was caused in the hospital. Then we take maternal and the child chart, and we do data abstraction. Then we go for microbiology real-time PCR analysis to identify pathogens in the specimen that may have caused the days. Then there is local and central histopathology analysis. We do the histopathology analysis locally in Haramaya University, and we also send it to CDC Atlanta, and we make sure that those results are in line. And if there is any discrepancy, those pathologists will have a virtual meeting and will come into a consensus. Then comes the decode panel, which is a panel of expertise. It comprises of pathologists, pediatricians, obstetricians, and public health specialists. So they will sit and they will discuss. They will see all the gathered information, including the myths and the verbal autopsy, the microbiology analysis. Then they will determine the cause of death. Not only they will determine the cause of death, but they will also decide whether the cause of death was preventable or not. So if it is preventable, they will also put preventable measures for the cause of death. Then after all that, the data has been collected, so we have to put it into action. So our data to action team will make sure that we will inform a range of policies and public health actions to reduce child mortality in the future. So for example, one example I could give you is neural tube defect is common, it has been shown to be common cause of death. So we are giving folic acid for mothers who give birth to a child with neural tube defect. So when we come to the result in discussion, so far we had 3,665 unique cases, and from this, the days was notified from Hiwat Fana, most of it, and Hiwat Fana is one of the referral hospitals, the main referral hospitals in eastern part, followed by the Haramaya Hospital and home days. And when we see from these unique days, most of the cases that were notified were stillbirths, followed by days in the first 24 hours and 1 to 6 days. So we can see that early neonatal days is very common. And from the days, most of it is from non-catchment area, and from catchment, the notification is mostly from Karsa site. And when we see the MITS acceptability, it's 73%. We can see that the MITS acceptability, it's not shown here, but the MITS acceptability is has rose from 57 to 92% in the given 3 years. And thanks to our social and behavioral science team. And when we see the MITS by site, most of it is from Karsa site, and followed by Haramaya, then Harar. And from those MITS cases that was done, most of them are stillbirths, followed by neonates, and then infant and children. So far, we have done 781 MITS cases, and for 468 of them, the code has been done, and the results have been communicated to the families. So when we see the cause of death in stillbirths, still it's not shown in the slides, but the most common cause of stillbirth is intrauterine hypoxia, followed by undetermined cause, and then followed by the severe form of neural tube defect, which is cranioschiasis. And when we see the maternal factors, it's preeclampsia and abruptio of placenta. When we see for neonates, the most common cause for neonates underlying cause is birth asphyxia, followed by respiratory distress, and then intrauterine hypoxia. And when we see the immediate cause of death, it's sepsis, followed by meconium aspiration syndrome and pneumonia. So when we see for neonatal sepsis, the etiology is mostly Klebsiella pneumonia, followed by E. coli. And when we see the causal pathway, most of the children had low birth weight, hypothermia, and birth asphyxia. So when we see for infants and children, the underlying cause of death is severe acute malnutrition, followed by sepsis and pneumonia. And sepsis and pneumonia are found to be the immediate cause of death. So when we see all cause of death in all age groups combined, non-infectious congenital conditions like intrauterine hypoxia, birth asphyxia, low birth weight, and meconium aspiration, and the like are seen, followed by undetermined, and followed by the cranioschiasis, which is the most common, the severe form of neural tube defect. So when we see the policy implications, as I've said earlier, for stillbirth, it's intrauterine hypoxia as a leading cause of death, and maternal contributors like abruptio placenta and preeclampsia. So we recommend that there should be a standard ANC follow-up, if possible, with ultrasound and mandatory BP measurement, and a system for referring the mothers to a higher level of care. And for the neonates, the major cause was neonatal death. As birth asphyxia was seen as a major cause of neonatal death, compounded with sepsis. So we recommend a proper obstetric care and with resuscitation and follow-up. And IPC provision is very mandatory because around 56% of the gram-negative bacteria like Klebsiella pneumonia are resistant to the current antibiotics. And when we see children, severe acute malnutrition is a major problem, followed by which is coupled with sepsis and pneumonia. So we have to make sure that we are giving attention to weaning diet, nutrition intervention, and vaccination. Thank you.
Thank you, Dr. Samrawit. We have used also exactly 10 minutes. Now I will call Dr. Gadise. Dr. Gadise Bakale is, I think, from Addis Continental Institute of Public Health. So all of us are from academic area. So you can present within 10 minutes.
Sure. Thank you, Professor. Akam ultani nagairtu. Mukaina gafitaira. So this is our title. Like Professor said, I came from Addis Continental. This project is done with collaboration JPIGO, funded by Bill and Melinda Gates. The title for this project is a feasibility and acceptability of a family care model to increase coverage and quality of postnatal care in Oromia, Ethiopia. So this is the outline. So maternal and neonatal mortality has been high, and it has been mentioned in different researches today also. As you have seen, it is still high. So, and postnatal care is also significantly low in our country. Less than 17% of mother neonates got a postnatal care after delivery in facilities. So, looking at this problem, an institution in Kenya called Think Place with human-centered designed this family-led postnatal care after assessing what is the actual cause of this. Why are this woman or mothers and neonates are not getting postnatal cares? So one of the things is cultural constraints, being a woman after she delivers, she wouldn't get out of the house. And the other thing they found from their research is the families, especially her husband, mother-in-laws and mothers are closely related in the care of the women. So what is it we can do from this? Is it came into family-led postnatal care. So this is an innovative model for reaching postnatal women and newborns with key postnatal cares service during the first week of life that leverages self-care principle. So this postnatal care model starts at health center with the midwife counseling not only the mother but also the families together on key postnatal danger signs, both in the neonates and mothers. So the midwife will give counseling to the families and the woman on how to assess this postnatal care using a visual cue. She will have a checklist, systematically counsel this. She will also have a script on how to systematically counsel this family. And then this visual cues will show them each danger signs which are anticipated in the postpartum period. So, and there is also a home care kit which includes blood BP device, temperature device, a photo booklet on danger signs and also normal neonates for both the woman and neonate, and a family guide book. So with this, it started, the family late intervention started at the health center. Thereby, the family takes this checklist and the home care kit from the community, and they would assess both the family and the mother will assess the mother will assess herself and neonate for the first week following delivery using the checklist. So it is hypothesized to increase the coverage of the key components of pregnancy within 24 hours, 24 to 72 hours, and 7 days. So it would also hypothesize to increase detection of danger signs and care seeking. So our objective is to assess the feasibility and acceptability of this model. So when we come to the materials, of course, we use pre and post cross-sectional studies. In between, there is an intervention. The pre and post intervention took 8 weeks to collect the data. In pre and post intervention, it was quantitative in both timelines and qualitative in post interventions. So our study populations were postnatal women, the woman's husband, family members, midwife, health extension workers, custodians, home care custodians, where the kit which compromises the BP and temperature and photo booklet would be placed within the community. So they're called home care kit custodians and the health managers of the health centers. So it was conducted in 4 health centers and the 17 catchment areas or qabalis under this health centers. It was from November 2022 to April 2023. Data collector were given training ahead of data collections. So when we come to the result sections, 119 and 110 in pre and post intervention periods, mother were included in this study. So one of the major things we checked is ahead of the time. So these mothers are who delivered at health center. So we will expect the postnatal check in the first 24 hours to be 100. So I'm not sure whether you can see it. The orange and blue colors. The orange shows the pre-intervention, before the intervention, and the blue shows after the intervention. Within 24 hours, as you can see, the postnatal check in the women's was not significantly different because they delivered at the health center, so we expect them to have a postnatal check. But in the pre-intervention, 97% got the postnatal check, while 100% got in the post-intervention period. The figures differ in the days following discharge from health centers. As you can see, only 11% and 3% of the women got a postnatal check, either by health extension worker or they also went to seek care at health center. So all these figures significantly decreased to 11 and 13%. But following the intervention, these women got 96% until the 7th day. The postnatal check, using the checklist, this woman, 96% of the women who have delivered have done these checks. So this is a significant change with a p-value of less than 0.001. So the same is true for the neonates. The figure is the same. It also decreases following a discharge until the 7th day. The percentage becomes 90 and 9 and 3, while it increases in the post-intervention to 96%. The other thing is, so in the post-intervention period, this woman's assessed, checked a danger signs in both themselves and the neonates, and then what? So out of the 110 women, 18% has identified danger signs. Of these 80 women, 65% of the women seeked care at health center, while 15% seeked care at health post. 20% did not seek care upon identifying a danger sign. And when we come to the neonates, also 3% of the neonates the family identified a danger sign in this neonates. All these neonates have seeked care at either health post or health center. So when we come to acceptability related questions, this woman's 95% of the women in the post-intervention period prefers this FMC approach as compared to the traditional approach, which is by health professionals. And 99% have liked this approach because they're getting the care at home or assessing the health of themselves and their baby at home. 95% of the women feel confident that the mother and the baby are receiving a good postnatal care when doing the assessment with a home care kit at home. So when we come to when we look at acceptability and feasibility, so 115 women in the post-intervention period delivered in the time period in our data population, of which 110 accepted this checklist upon discharge from health centers. So 110, which makes it 95.5%. Out of the 110 mothers who collected the checklist, 105 retrieved the home care kit from the community or the custodians, of which 90% of these women have returned it upon using this home care kits. And 88% of this women returned the checklist they have used it to the home care kit. To the home care kit custodians, and 66% of this checklist were retrieved by health extension workers, and then this health checklists were filed on the family folders at health post level. So when we come to feasibility, the home care kit stayed for 7.5 days at the, on average of 7.5 at the home, the woman's home, and there was a register. When the home care kit custodian give the kit to the family, they will register it. And 82% of this register were completely filled by the home care kit custodians. 95% of the home care kit and 100% were complete and functional after the 2 months of data collection. 90% did not face any challenge while receiving and retrieving the kit, and 6% of the family communicated those families who have used the home care kit previously. When we come to the feasibility of the BP and temperature, so this BP and temperature are user-friendly, and they would only show colors, red and green. So red indicating health, red indicating danger. So 83% of the women have successfully used this without no difficulty, and 92% of the women felt confident while using these devices. And as for the checklist, 86% of the women have used this checklist without no difficulty, and 94 have reported to have a confidence while using the checklist. When we come to the qualitative studies, so this approach, family-led approach, the qualitative study have shown that it was highly acceptable in postnatal women, the families, the home care custodians, community members, and health providers. It has made possible for many mothers to access the pregnancy service at home. Without this model, which they have not gotten it. So family-led postnatal assessment care is feasible to be implemented. So when we come to policy implications, systematic and improved discharge counseling at the health center for postnatal mother and family is essential. The other thing is involvement of the family members on discharge counseling for better follow-up of both the mother and the newborn. The other thing is usage of a checklist for postnatal check of the woman so they can easily remember and check the symptoms they're supposed to check. The last thing is we recommend testing this dependency model in high volume health facilities and different contexts to help understand more the scalability of the family-led postnatal care. That's it from my side. Thank you.
Thank you very much, Dr. Gadise. So please, would you stand up for a while to make a sort of exercise what you like? Thank you very much. Have a seat. Really, I am very much fortunate in having gender equality on this session compared to the previous one, not gender equity, because I am much gender sensitive person. What we have learned from this presentation is from eastern part of our country, from Harar area, we have learned the trajectory of maternal and under 5 mortality and the cause. The two presentations focused on this area. And from southwestern Ethiopia, from Jimma area, we have seen the randomized control trial on the management of mother and infant children, focusing on malnutrition. And the third one on central part of Ethiopia, we have seen the new innovative approach of postnatal care, family-led postnatal care. As we know, the coverage of postnatal care is very low in different surveys and administrative reports. So to combat and overcome this, they have tried their best in having innovative model and come up with some encouraging result. Based on this, I will give the floor for the audience to ask some questions and the concerns, just having 3 minutes maximum, targeting for the presenters. So raise your hand, please. 1. Use your time. If you want to go to your home. 1. I don't see. 2. 4. Dr. Zallake, have you raised your hand? Okay, no, you are Professor Zallake. We have also Dr. Zallake there. Okay. Okay, give him.
Okay, thank you for the opportunity. I just appreciate all the presenters for their nice presentation, and I have only one idea. It may not be really a question. It is for the second presentation, I think Dr. Marga on maternal mortality. They have done very useful data showing trends over time, and it shows there is no much change or reduction in terms of maternal mortality. It looks somewhat stagnant. In fact, after, if you look at also other data like ANC coverage, institutional delivery, in most cases it's like constant after some reduction. So the question is, the study is about determinant. I feel like determinants are much more broader. We have to really go beyond like describing in terms of age as a determinant. We need to look at more the structural issues, the socio-cultural issues, the anthropological aspects, a more systematic way, because we are not able to explain it, why it is still there is no reduction. And I feel you have, if you are continuing on this, studying, you will continue this specific area, searching it. Please go to the more deeper, the structural things that can shape all those factors instead of very simple factors which is very much common in all papers, like age and something like that. So I want to just have this reflection. Thank you. Otherwise, things are very good.
Thank you, Professor Zode.
Number
2. Okay, please, would you tell us your name?
Yes. My name is Tasamma Dabala from Oromia Regional Health Bureau from Health Research Department. Thank you for your nice presentation for all presenters. My question is directly go to Dr. Samarawicz. So I've heard some in result part, result notification to partner, how it was visible for postpartum sample result notification for partner rather than using for action. How it was visible for after this, why you notify the results to the partner rather than using that information for action? Is it visible? And the second question also goes to Dr. Samarawicz. There is a lot of causes for under 5 children. Is all causes of death are only from clinical data, or are you capturing community level data? Can we conclude only by capturing? Is it representative that is by as facility by itself? It is representative, or are you going to collect through the surveillance system, through the notification of community and doing a verbal autopsy, what was happening before the death, and identify the determinant causes rather than clinical causes of the death? Thank you very much.
Thank you, Mr. Tasamma. Please, if there is any concern and questions, I will give you a chance also. Dr. Adunya.
Thank you very much. My question, my comment is not referring to the presenters, but in terms of tackling the theme of this research, annual research, I think tackling health service delivery bottlenecks through evidence-informed decision-making. I would like to challenge the organizers in raising one of the important questions for comment, like to be documented, like tackling health service delivery. One of the bottlenecks, as far as I'm concerned, is that climate change is one of the challenges. If you have a good, well-equipped health service, well-staffed health service with good quality technology, surveillance system perfect, if your health service is situated in a flood-prone area or drought-prone area where there is no utilities, I think this is one of the challenges. I would have loved some aspects of climate change. I heard during the opening session, the keynote speakers have mentioned about climate change. They have mentioned about some other challenges we have been through. So I think this is one of the missing opportunity for the organizers to consider in their note-taking, and it could be communicated. Thank you very much.
Still, I will give the chance if there is any concern before directing to the presenters. Okay. Doc, I forgot your name. Excuse me. Yibaltan from Jimma University.
Yeah, thank you, Dr. Salashi and all presenters. I appreciate your work and presentation. Just to add one question to last, I think, presenter, Dr. Gaddise, especially the acceptability and feasibility of the intervention, and also the self-care part of some clinical components. Have you validated the self-care measurement process in that community, and also the acceptability and the feasibility issues should need a validated tool? So have you validated that tool or adapted it? Just as my concern. Thank you.
Okay, thank you. Okay, Dr. Yadata.
Okay, thank you, Mr. Chairman, for the chance, and thank you all, to all the presenters. So my question goes to Dr. Marga. One of the very significant factor still contributing after 42 days of birth is infection. Is what kind of infections are common during that period? Did you see by just decomposing down this infection so that we can plan against this infection in terms of the translation activity? So as an organizer, Dr. Adunya, yeah, your comment is well noted, and yeah, we put the emergency or the humanitarian crisis as sub-theme, yes, but finally there was no abstract submitted for that, and at the end of the day we try to merge into the emergency setting and the leadership. It's just for the information. Yes, thank you.
Thank you very much. Really, I think it is enough. I directly forward the direction for the presenters. I think I will give the chance first for Dr. Marga.
Okay, thank you all. Actually, two questions has been raised. The first one is, I think it is comment. My analysis wouldn't go to the high levels of structural and others environmental issue to capture the determinants of maternal mortality. So we will follow in the future. Actually, what we did for after 42 days is there is a category of classification using ICD-10. Based on that, there are a lot of classification. Among that, we are grouped together so the cause that has been okay, for the time being, I couldn't mention which one is first for Dr. Adeta, but I can communicate you through in person. Thank you.
Okay. Two questions have been raised, and answering to the first one, I did not say partners, I said families. The results have been communicated to the families because we have the responsibility, and the families have the right to know what caused the days of their child. So that's what I meant. And our data to action team is working continuously, and as an example, I have said the folic acid. Another example is, for example, the IPC provision at the hospital, because sepsis is one of the cause of death for neonates, and hospital-acquired infection is one of it. So in order to put into action our data, we have collaborated with the hospital to work on infection prevention and control. And I think this answers my question, your question, I mean. The next one is the days notification is not only from the hospital, it's from the community as well. So we get the notification from when we get the notification from the community, we go to the community, we counsel them, we take the consent and take the body to the hospital. We do the minimal invasive tissue sampling, and then we return the body to the families. And when it is from the hospital, we do the post-mortem examination at the hospital and give the family the body. So that's what we have been doing, and it's not only from the hospital, it's from the community as well as the hospital. And for the verbal autopsy, it is in addition to the myths, we need other information as to what was happening around the days of the child. So we take verbal autopsy from the families. And if the days happened in the hospital, we are going to see the medical chart of the mother as well as the child. Then that's going to be put into a summary, and it will be presented for the decode panel. So this is.
Okay, thank you for the questions. When I come to the first question, being the self-care model being tested. So before we have implemented this in these 4 health centers, we have tested it at one health center for 6 weeks. Before that, after the design was prepared, the model was prepared, expert opinion was incorporated, and then tested at, piloted at one health center. After that, after incorporating the comments or suggestion from input from one health center, which was piloted, we again implemented this intervention into the 4 health centers. As for the tools, we have used, we have pre-tested it. There were some components which has been validated and being used as in EDHS. We took from that, and the others, after the pre-test, we have incorporated comments, and we have also calculated the alpha score for the internal consistency. So I think that's all.
Thank you very much for your response. And finally, please, if you have anything to say about the fixing of the theme for this conference, in the inclusion of, for the inclusion of conflict-affected areas from the organizer. I see Abasa or any other group member from the organizer in the Oromia Regional Health Bureau. Or can we accept as a comment for the future? Or can you say something?
I think Dr. Yedata address ለማድረግ ሞክሯል እንደ ኮመንት ደግሞ እንወስደዋለን የምለው probably.
So we can take as a comment and improve for the future. I think that's better. And finally, really, we have learned a lot from their presentations. I believe the results have contributed a lot for policymakers, for programmers, as well as for the implementers. Because nowadays, we are very much striving in achieving some of the targets which was set to achieve in the Sustainable Development Goals. And also, we have a target plan to achieve HSTP2 during 2025, and left only with 2 years. In that, the Minister of Health, I can talk on behalf of Minister of Health, the Minister of Health is just searching an innovative idea to speed up the coverage as well as the reduction of the problems, not only the mortality, the disease burden, and the nutritional problems. So I think even if some of the findings are in the interim stage, they come up with some encouraging results. Saying this, I think I congratulate and thank all the presenters, and finally thank the Oromia Regional Health Bureau for organizing such like learning and encouraging forum, and for inviting me as a moderator as well. Thank you very much. So if there is some announcement, I will leave the floor for...
announcement ይኖረናል ነገ እንድትመጡ ነው ሌላ